Hello there, Dr. Sullivan here again, chronic pain GP, and today's video is about a condition called lupus, or it's also known as systemic lupus erythematosus, or SLE for short. This video is prompted by an interaction I had with a patient which I saw in my pain clinic. The interaction was filmed for television for a Channel 5 series called GPs Behind Closed Doors, and that should be airing fairly soon. Now, the patient did have a diagnosis of lupus, but she also presented with signs and symptoms of fibromyalgia. And my previous video, done fairly recently, concentrating on fibromyalgia. Like many definitions in medicine, it has its basis in the Latin language, and lupus essentially comes from the Latin meaning wolf. So the story goes that the rash, which is quite prominent in patients who have lupus, is representative of a wolf bite. I'm not sure about that. However, we do know that it is a chronic autoimmune rheumatological condition. Unfortunately, there's no cure at the moment, and as with most rheumatological conditions, it does seem to have a slant more towards affecting females than males. Now, traditionally, the diagnosis is made via clinical examination and history taking, including the presence of joint pain and stiffness associated with tiredness, and the typical skin rash, often present over the nose and cheeks, also known as a butterfly rash. And often there is an associative weight loss, swelling of glands, skin sensitivity to light, and there's often a condition called Raynaud's, which is essentially poor circulation in the toes and feet. Now, there is a newer classification which is due to be out towards the end of this year and early next year, and that is a classification jointly advised by the American College of Rheumatology and the European League Against Rheumatism, and these will concentrate mostly on clinical points and blood test results. Now, autoimmune conditions are conditions where the body essentially attacks itself, its own healthy cells, tissues and organs. Again, similar to fibro, there is likely to be a genetic component here with an environmental trigger as well. They saw that there's about 50,000 people affected in the UK, and the vast majority, about 90% or so, are female. Now, in primary care, the diagnosis, I feel, is one which can be made on history, examination, and a blood test, and that particular blood test is something we call an autoimmune screen. Now, if the autoimmune screen is even moderately positive, it often prompts a referral to the secondary care doctors, in particular the rheumatology team, who can then make an official diagnosis. They themselves may decide to do some further investigations, including scans looking at perhaps the heart or brain, as well as blood tests covering the liver organ and kidneys. Quite simply, often the impact of the condition on patients could be classified as mild, moderate or severe, and these are often managed differently. Management options, again, I've split into non-pharmacological and pharmacological, are as follows. So gentle stretching, exercise and strengthening are vital in patients and most rheumatological conditions. Lifestyle changes are essential, including reducing alcohol and stopping smoking. A healthy diet is important, as well as relaxation and rest. Skin protection is also essential, particularly during the summer months, and I feel that because it's a chronic condition which can vary in severity, when I see patients or employees as part of my occupational health work, I do think it classifies as a disability under the terms of the Equality Act 2010. Now, moving on to the pharmacological treatments. In primary care, we often prescribe anti-inflammatories, and often with GI protection. A specialist drug which is often prescribed in secondary care and then handed over to primary care is hydroxychloroquine. Steroids can be used long term, but these can have side effects, and we can often use steroids in flare-ups. And then the more specialised medications are usually started and monitored by the rheumatological team, and this one in particular is called rituximab, which is a monoclonal antibody. Although this condition is chronic, it's lifelong, but it's not thought to be a life-limiting illness. although the severe end of lupus can impact significantly upon patients and their quality of life. So in conclusion, this is a fairly rare rheumatological condition for primary care doctors. However, it can have a serious impact upon patients' quality of life. Although treatment can be started in primary care, often the diagnosis and more specialised treatment is handled by our secondary care colleagues. Now, my next video will be probably one of the most common rheumatological conditions, and that is osteoarthritis. And all that's left to say is thank you for watching. Please subscribe, like the videos, share far and wide, leave any feedback down below, and I will see you next time.